Managing sodium is the major function of the kidney. Of course, this is true because sodium is the most abundant cation in your ECF. It's the major cation in the plasma and in the interstitial fluids. Not the ICF, though, right? Potassium gets that compartment. Think of all the ways that the kidney used sodium as a feedback mechanism to regulate filtration, as in that tubuloglomerular mechanism. The sodium content of your body may change. You eat a salty meal, and that raises the amount of sodium in your plasma, increasing your osmolarity. However, the concentration of sodium in the ECF will remain the same. Instead of lowering sodium, the water volume is adjusted among the fluid compartments to maintain the same concentration. This is called fluid shifting. Instead of moving around sodium, you move around water between the compartments. When you eat a salty meal, it raises your sodium content, and your body's going to respond by raising the volume in the plasma. This can be accomplished by thirst. Adding more water is like adding more water to a water balloon. The pressure increases. But the water doesn't stay in the plasma. It seeps into the interstitial fluids, increasing the volume of that compartment. And the IF overflows into the ICF, increasing the water pressure in each and every one of your cells. Water balance is strongly coupled with the control of volume and, by consequence, blood pressure. There are two important hormones that play a big part in regulating sodium, in regulating your osmolarity. Aldosterone, which helps you keep sodium, and ADH, that helps you keep the water that follows. Yes, there are other hormones that dip into sodium regulation, but we're going to focus on ADH and aldosterone as the two main hormones. Hyponatremia and hypernatremia are disorders that result from too little or too much sodium. Remember, your body manages water by using the sodium concentrations to create gradients. Hypernatremia is a condition in which sodium concentration in the blood is higher than normal. One common cause of this is dehydration, especially in elderly individuals or people with limited access of water. For example, if a person loses a lot of water through sweating or diarrhea and doesn't replace that water with fluids, the sodium concentration in the blood increases. Your ECF osmolarity increases because there's less water to dilute all those solutes. Hypernatremia can cause muscle twitching as the interstitial fluid concentration of sodium gets really high, allowing a lot of sodium to leak into cells using those leak channels and possibly causing some depolarization. The treatment involves very slowly rehydrating the patient, usually with just IV fluids that are hypotonic. The goal is to gradually restore the balance of water and sodium. Too rapid correction can cause cerebral edema because the first cells that are serviced are brain cells. Hyponatremia occurs when blood sodium levels fall very low. A classic example of this is something called water intoxication, which more specifically is called hypotonic hydration. This can happen if someone drinks excessive amounts of water in a short period, like during an endurance sport, without replacing the electrolytes. The excess water dilutes the sodium in the blood, and muscle cramps occur or weakness. The treatment of hyponatremia depends on the cause, right, and the severity. Mild cases, you might only just need fluid restriction, but more severe cases are treated with a hypertonic saline administered carefully, right, to avoid correcting the levels too quickly, which would cause fluid shifts to happen more rapidly than they could. Aldosterone is released by the cortex of the adrenal gland and acts on the distal convoluted tubule of the nephron. This allows the DCT to reabsorb sodium, moving it from the filtrate to the blood. And as the sodium moves, water follows it, ultimately increasing the volume of your ECF. So again, the concentration of sodium is held constant by affecting movements in water. There is a disease called Addison's disease where you basically generate tons and tons of aldosterone. And so to satisfy the kidney's desires under that much aldosterone, you have to consume a lot of salt and a lot of water. You spend your life bloated and uncomfortable. Surgery to remove part of the adrenal cortices helps Addison's. Estrogens are also hormones that can affect water balance. Basically, they mimic aldosterone, causing the same type of bloating. But estrogen's like super aldosterone. So it's like getting Addison's disease every month. Anyway, glucocorticoids like cortisone, they also act like super aldosterone. And both of these, they promote edema. Angiotensin II is a hormone that controls the release of aldosterone from the adrenal cortex. Remember, there were granular cells on the afferent arterioles, and they release renin that gets processed into angiotensin II. When there's a decreased sodium or low blood pressure in the systemic circuit, that is when angiotensin II is released.